So this presentation, I'm going to be doing epinephrine. Um, for my first slide, just pretty much epi is also known as epinephrine or adrenaline or epi. I might refer to any of those throughout my presentation. Um, Pretty much epi is a hormone that triggers our fight or flight response and initiates our defensive systems by causing a release of glucose from our muscles and liver into the bloodstream to create that burst or rush of energy when you're scared or excited. Epi can also act like a neurotransmitter in certain tissues by transmitting signals between nearby nerve cells, and it gets synthesized from either phenylalanine or tyrosine, both of which are amino acids. And the two adjacent hydroxyl groups are put on the aromatic ring, making a catechol. The hydroxylations from the intermediate L-dopa, which will convert to neurotransmitter dopamine and norepi, and lastly epi. Those three together are what we call catecholamines. And when the nerve signals to the adrenal gland, it causes norepi to convert to epi, which then it will get released into the blood and causes vasoconstriction in certain areas of the body and tachycardia, and you'll get like a rise in your blood glucose. Epi can also connect to the liver, muscle cells at certain receptors on the exterior of the cell, which will activate enzymatic reactions within the cell, creating the synthesis of CAMP, which stands for cyclic adenosine monophosphate. Since epi is unable to go across the membrane of the cell, the hormonal signal will transmit within the cell via the CAMP, and the phosphorylations activate enzymatic reactions, which causes glycogen phosphorylation to activate. That's the enzyme that breaks down glycogen and causes glucose to be released into the bloodstream. When there's a reuptake into the neuron or breakdown to metabolites that are inactive by the COMT, which stands for catechol methyl, and MAO, which stands for monoamine oxidase, the action of the neurotransmitter of epi is terminated. The second messenger effects inside the cell are terminated by enzymes that break down the CAMP and phosphates that reverse the action of the kinases by removing the phosphates. Epi also acts like a regulatory step when fatty acids are becoming synthesized. Activity of the first enzyme, acetyl coenzyme A, carboxylase, is regulated by phosphorylation, and the phosphorylated enzyme is inactive, and the dephosphorylated enzyme is active. And epi, through the second messenger, CAMP, prevents dephosphorylation of the acetyl coenzyme A, carboxylase, which makes it inactive and stops the synthesis of fatty acids during our fight or flight response. And the organism needs to release energy in the form of glucose and fatty acids rather than store energy as glycogen or fat. Metabolism, epi or nepi, I found this article that was written by Julius Axelrod. This is actually kind of an old article that was written back in the 1960s. But I found some pretty interesting information. He mentions the physiological actions of epi and the other sympathomimetic amines that are pretty well established, yet the metabolism of these compounds isn't really understood that well, according to his article. And although several enzymes have been shown to transform these amines in vitro, the part that they play in the intact organism has been hypothetical. Information concerning the fate of sympathomimetic amines has become available, and many new enzymes have been found that are of importance in the transmission of these amines. As far as metabolism of the catecholamines, when epi or norepi is administered to a man or some kind of an animal or species, only a really small amount of the compounds that are excreted are pretty unchanged, and that kind of tells us that they undergo almost complete transformation in the body. Many pathways have been proposed for the metabolism of catecholamines in vivo, and they're involved in the transformation of exogenous or endogenous catecholamine hormones. In the past, the routes suggested for the metabolism of these amines included deamination, oxidation, and conjugation. According to this figure here that I put up on my slide, it kind of shows the metabolism of epi and norepi. 1, 6, and 10 are catechized by the catechol methyltransferase S-adenosyl methionine, serving as a methyl donor, and divalent cations are required. 2, 3, 4, 5, those are reactions that take place in 2 steps: the amination of the MAO and to form the corresponding aldehyde, followed by the oxidation of by aldehyde dehydrogenase and diphosphopiridine nucleotide. 7, 8 in many species, conjugation occurs by the transfer of glucuronic acid from the uridine diphosphate, glucuronic acid by transferring enzyme in the liver microsomes. And G is the reaction that has been shown that happens in vitro in certain species. I found another article talking about episynthesis and the release of it. So epi is synthesized from norepi within the adrenal medulla, which are small glands associated with the kidneys, and preganglionic fibers of the sympathetic nervous system synapse with the adrenals. Activation of these preganglionic fibers releases acetylcholine, which binds to postjunctional nicotinic receptors in the tissue, and this leads to stimulation of the norepi synthesis within the adenomedullary cells. And unlike sympathetic neurons, there's an additional enzyme that adds a methyl group to the norepi molecule to form epi. The epi is released into the blood, perfusing the glands and carried throughout the body. As far as removal and metabolism of norepi and epi, the binding of norepi to its receptor depends on the concentration of norepi in the vicinity of the receptor. So if the nerve stops releasing norepi, then the norepi concentration in the junctional cleft will drop, and norepi will leave the receptor. And there are several mechanisms by which the norepi will be removed from the intracellular space and from the post-junctional receptor. A couple quick things. Some of the junctional norepi diffuses into the capillaries and is carried out by the tissue by circulation. So high levels of sympathetic activation in the body increases the plasma concentration of norepi and its metabolites. Some of the junctional norepi is metabolized within the extracellular space before reaching the capillaries, and a small amount of norepi is taken up by the postjunctional tissue and metabolized. Norepi and epi are metabolized by catechol methyltransferase and MAO. The final product of these pathways is MVMA, which stands for vinylmandelic acid, and that product with other precursors, norepinephrine and epinephrine, are measured in our urine and plasma in diagnosis of pheochromocytoma, which can cause really bad hypertension and some cardiac abnormalities or arrhythmias. Another study that I that I found, the talks about norepinephrine and epinephrine are how they're the O-methylated metabolites of norepi and epi, whereas DHPG, which stands for hydroxyphenyl glycol, is a deaminated metabolite of for both norepi and epi. In the study, in the article, compared the production of norepinephrine, DHPG during the tracer and high dose infusions of norepi and epi in rats with and without inhibition of the COMT or the A and B forms of MAO. And the animals got infusions from the norepinephrine and the epinephrine so that they could kind of compare and contrast the plasma clearances and spillovers of the norepinephrine and the epinephrine when there is and when there isn't the MAO inhibition. Inhibition of the COMT increase plasma DHPG and decrease the plasma norepinephrine and epinephrine. And the increase in norepinephrine and epinephrine after the MAO inhibition kind of showed blocked deamination of the norepinephrine and epinephrine by the MAO-A, however, not the MAO-B. The A form was responsible for deamination of norepi, and when it was infused with epi, it was deaminated to DHPG, not nearly as efficient though as the norepi. And the tracer, where O-methylated, kind of pretty very similar. After the MAO inhibition, the norepi was O-methylated more efficiently than epi, and increased plasma norepinephrine after the MAO inhibition reflected the combined effects of a decrease in the plasma clearance of norepinephrine and an increase in the spillover of norepinephrine into plasma, whereas a smaller increase in plasma epinephrine was kind of due to the decrease in the plasma clearance of epinephrine. So epi and epinephrine are not deaminated or the extraneuronal sites of O-methylation. So any norepi is both O-methylated and deaminated, proportionally more deaminated than the O-methylated as the concentration of norepi increases. So overall, it kind of tells us that the preference of norepi over epi for neuronal pathways and metabolism, but indicate it's a lot more complex and the differences between them and the metabolism of norepi and epi by the extraneuronal L-methylation and deamination. The circulating catecholamines, epi and norepi, kind of come from two sources. Epi is released into the adrenal medulla during the activation of preganglionic sympathetic nerves innervating this tissue, and activation occurs during times when we're we're working out, or anytime we have stress, or we're going into heart failure, or going through a divorce, whatever it may be. Norepi is also released by the adrenal medulla. However, the primary source of the circulating norepi is the spillover from the sympathetic nerves that are innervating from the vessels. So normally, a lot of the norepi gets released by the sympathetic nerves. Is taken back up by the nerves, where it gets metabolized, and a really small amount of the norepi that's recycled and metabolized kind of diffuses into blood and circulates. And when there's high sympathetic nerve activation, the amount of the norepi entering the blood goes up, obviously. As far as what does the circulating epi do, increases our heart rate and inotropy by beta-1 adrenal receptor mediated vasoconstriction, and systemically through our arteries and veins. Our post-junctional alpha-1 and alpha-2 adrenal receptors, we get vasodilation in muscles and liver. When at lower concentrations of epi, our beta-2 adrenal receptor, and if we're at higher doses or concentrations, we call vasoconstriction, or the alpha adrenal receptor mediated. But overall, cardiovascular wise, our response to low to moderate concentrations of epi, what it'll do is it'll just pretty much increase our cardiac output, kind of redistribute the cardiac output to the muscular and hepatic circulations. We might get a minuscule change in our mean arterial pressure, or MAP. But even though our cardiac output is increased, typically arterial pressure doesn't really change because of the SVR kind of drops down due to the activation of our vascular beta-2 adrenal receptors. When there's a higher concentration, the epi, of course, will increase our vessel pressures, and because of how it binds to the alpha adrenal receptors on blood vessels, um, which offsets the beta 2 adrenal receptor mediated vasodilation. So the effects of low, medium, and high concentrations of epi on SVR is kind of shown in that bar diagram that I posted on this slide. Um, when there's like lower levels of plasma, epi kind of binds to the high affinity vascular beta 2 adrenal receptors and causes vasodilation. And this kind of causes a fall in our SVR. And then when our concentration gets higher, lower affinity alpha adrenal receptors will bind to epi, and that kind of really offsets the beta 2 adrenal receptor the vasodilatory effects that it has. And when there's high concentrations or dosage, a lot of the alpha adrenal receptors bind to epi, and and kind of the relationship between vasodilation and vasoconstriction actions of the of epi will kind of shift and more towards vasoconstriction, which would of course increase our SVR. As far as blocking the actions of the catecholamines, because catecholamines act on the heart and blood vessels through the alpha and beta adrenal receptors, the actions of the catecholamines can be blocked by treatment with, obviously alpha blockers or beta blockers, and when those are blocked, that kind of alters the response of the catecholamine because of the other adrenal receptors will kind of still bind to the catecholamine. So if there was like a medium concentration of epi given in with alongside an alpha adrenal receptor blockade, then the vascular beta 2 adrenal receptor activation would be kind of unopposed by the vascular alpha adrenal receptor activation. That kind of causes there to be hypotension because the vasodilation that comes from the beta 1 adrenal receptor. As far as, a lot of us kind of know epi and what it's used for. It's used in a lot of emergencies, situations like codes and whatnot. It can treat a lot of, anaphylactically, a lot of severe allergic reactions. People have their EpiPens, any kind of allergen, insect bites, food, drugs, all the above. It can improve our work of breathing. It can stimulate our heart. It can increase our blood pressure. It can reverse hives, reduce swelling. I found an article that talks about that epi is like the primary drug that we give during CPR to reverse the cardiac arrest, and how epi increases our arterial pressure, blood pressure that we were kind of talking about, and our perfusion of our coronary arteries, and by the alpha 1 adrenal receptor agonist effects. But it really, as far as our timing and our dosing, there's not a whole lot of information. Not a lot of whole studies have been done, especially like on animal studies or whatnot. So it was kind of, this kind of article kind of showed whether epi really gave an overall benefit for the patients. So they did a randomized control trial that indicated that for epi for the out-of-hospital cardiac arrest patients, obviously it'll increase their pulses, but it doesn't really help out, long-term survival. It's more of like a short-term effect in a way. And so a large they had a well-controlled observational study that kind of show that even though we had increases in our return of pulsation, it actually reduced our long-term survival and functional recovery from the CPR. And there's obviously patients who suffer from VFib didn't do nearly as well in that study. The lab data kind of shows us that the epi kind of induced reductions in the microvascular blood flow during and after the CPR may kind of offset the beneficial epi induced increase in the arterial pressure during the CPR. So in that data, it kind of confirms the epi was just when it was administered during codes, an increased short-term survival, but not so much. There wasn't really any beneficial effects for like long-term care or outcomes, I should say. Also, as far as for if you want to know dosing, anaphylactic and bronchospasms, typically I want to say 0.3 to 0.5 milligrams of SQ or IM, 1/1000 dilution, and that kind of inhibits histamine release and helps relax our bronchial smooth muscles. As far as BT or VFib, we give 1 milligram IV or every 3 to 5 minutes, and we can go up to about 5 milligrams, and that can be given through the ET tube or but what that would do is kind of increase our heart rate, our inotropy or contractility, and our SVR. As far as contraindications, patients who are pretty much hypersensitive to sympathomethylamines, probably non-anaphylactic shock patients, and as far as adverse reactions, I would say anxiety, headache, palpitations, all the obvious ones. And here are my references, and that's it.